Good evening, everyone. I warmly welcome you all to today's international session under the International Free Workshop 2026 series. I am Sumaya Bashadola, Assistant Academic Lead at Bangladesh Institute of Innovative Health Research, and it's truly an honor to host this important session today. Thank you for joining us from different regions and professional backgrounds. Bangladesh Institute of Innovative Health Research is a non-profit, research-based organization established to promote a strong research culture, especially among undergraduate students. We focus on empowering students and professionals through research training, academic mentorship, and skill-based programs, creating a bridge between knowledge and real-world impact. Now, it's my great pleasure to introduce our esteemed facilitator for today's session, Mr. Jusu Musa. Mr. Musa is a seasoned public health professional and field epidemiologist with extensive experience in health system strengthening and emergency response. He holds a Master of Public Health and a Bachelor of Science in Public Health and is also a certified AVoHC-SURGE Health Emergency Responder. He currently serves as a Principal Public Health Superintendent at the Ministry of Health, Sierra Leone, where he plays a key role in disease surveillance, outbreak investigation, and public health program implementation. In addition, he is a trained field epidemiologist through the Field Epidemiology Training Program with hands-on experience in managing public health emergencies and strengthening response capacities. With his strong background in epidemiological research and frontline health operations, Mr. Musa brings valuable practical insights and global health perspectives to today's session. We are truly privileged to have him with us today to guide us through today's session, Strengthening Health System in Africa and Low and Middle Income Countries, Challenges, Innovations, and Future Directions. This impactful international workshop focused on exploring the current challenges and emerging innovations in strengthening health systems across Africa and other low and middle income countries. Before we begin, a few quick instructions for today's session. The session will run for approximately 1 to 1.5 hours. The language of instruction will be English. If you have any questions, you may ask your question through the chat box or orally during the designed Q&A segment. We encourage active participation to make this session interactive and impactful. So now, without further delay, I would like to invite Mr. Jusu Musa to lead us through today's session. We are excited to learn from your expertise, sir. The floor is yours.
Thank you so much. And greetings from Sierra Leone. As you heard, my name is Jusu Musa, a public health professional with over 10 years of working experience in Sierra Leone, specifically in health system strengthening, health emergency preparedness and response, and disease surveillance. And I currently serve in the Ministry of Health in Sierra Leone. And I currently leading so many health interventions in Sierra Leone under the Ministry of Health. ranging from environmental health, WASH, and public health emergency coordination at both national and international level. My work has largely focused on strengthening community-based health system, improving data decision-making, and supporting rapid response mechanisms during outbreaks and other public health emergencies. I have had the opportunity to collaborate with national and development partners, including WHO, UNICEF, UNFPA, IOM, and so many other more, particularly in the areas such as risk communication, community engagement, outbreak investigations, health data management, cross-border interventions, and above all, health system strengthening. Today, I'm pleased to facilitate this session on strengthening health systems, particularly within the context of Africa and other low and middle income countries. This is an area that is not only passionately important to me, but also deeply relevant to the realities we face in our health systems. I look forward to an engaging and interactive sections where we can share knowledge, experience, and practical solutions for our continent. Thank you all. So, my presentation this evening will go like this. We'll be talking about health system, wherein we bring in the WHO 6 health building blocks, structure, function, and that of interdependencies. Our challenges in the LMICs, low, middle, and income countries, taking the fact of workforce, financing, infrastructure, and surveillance gaps in our LMICs. I will bring in some case studies from our fields in Sierra Leone. We'll be talking about our 2014-2016 Ebola outbreak, also the pandemic intervention in Sierra Leone of COVID-19, our Mpox outbreak in Sierra Leone, and the cholera outbreak in Sierra Leone, specifically the district that I'm serving as one of the team leads. We're also talking about the digital innovations, where we'll be looking at the DHIS2, the community-based surveillance, the rapid response team intervention, the telemedicine, and that of the health information hub. Last but not the least, we'll be talking about our future directions, where we will be talking about the domestic financing of health system, universal health coverage, workforce investment, and regional collaboration. Today, I want to hear from participants and all those that are called. What do you understand about health system? I just want to make my presentation very interactive. What do you understand about health system? Okay. Health system is integrated component that comprises of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. So based on our WHO building blocks, we look at our governance and accountability sections. Who responsible for policy, why policy in our health system, the coordination, why coordination in our health system. We also look at the funds and the financial protection of our health system, the skilled workforce, motivated skilled workforce in our health system, efficient health service delivery with equity healthcare interventions. Also, in the health block system, we'll be looking at the data for decision making. Last but not the least, our medicines, vaccines, and other medical supplies. In Sierra Leone context, based on our post-conflict in 2002 and the post-Ebola in 2016, Sierra Leone has rebuilt its health system, wherein we have our free healthcare initiative and that of the National Public Health Agencies. So, in our LMIC context, 80 to 85% of the global population lives in the LMICs. But nonetheless, majority of these global populations, we are facing high burden of disease. And we have limited financial resources that can upkeep our health service delivery. As you may know, billions of people lack full access to essential health services. So I'll just give you a snapshot of our Sierra Leone profile. Sierra Leone is a very small country in West Africa with approximately 8 million population across the 16 districts. And our doctor to patient ratio is approximately 1 per 5,000. And we had our civil conflict 1991 and ended in 2002. Our devastated Ebola epidemic was in 2014 and ended in 2016. And we established the free healthcare initiative in Sierra Leone in 2010, wherein we have categories of people in the country that can access health facility and health services for free. Number one is the pregnant women, lactating mother, under 5s, people living with disability, and Ebola survivors. So these are the categories of our free healthcare initiative in Sierra Leone that are accessing our free healthcare services on free basis. We also decentralized our health system, wherein a district health management team is responsible and overseeing all health and health-related interventions at that district level. So our common LMIC features today we'll be talking at, we have funding constraints in which we are heavily reliant on international donors. We also have the supply chains that are very, very fragile, and always we have stock out of medicines, both essentials and other medical consumables at the health facilities. We also have disparity in the area of urban-rural healthcare force or health workforce. We also have weak surveillance system infrastructure in our various LMICs. My country is not included, it's not excluded. We have a high burden of preventable disease such as malaria, typhoid, you name it. Nonetheless, we have limited community trust in health systems in many parts of Africa and other LMICs. Our major challenges, as you have seen, what is common or are common in our LMIC context, I just have out 6 major areas that are major challenges for our health system in LMICs. One, the funding. As we are highly dependent on donor funding, Africa Head of State met in 2001 in Abuja, wherein it was recommended and they endorsed that 15% of the national GDP should be allocated for health system in Africa countries. But this is not, it's far yet to be met in most of the Africa countries. For Sierra Leone, our workforce shortage, we have less than 400 doctors that serving population of about 8 million. WHO recommended that 44.5 health workers per 10,000 population. When in Sierra Leone, the rural areas are still facing the greatest challenge. So we are far below that recommendation of WHO. So we still have delay in outbreak detection or reporting due to our poor HMIs, as well as laboratory staffing, infrastructure, motivations. We witnessed this in our suspected mpox case in Falaba district, one of the districts in Sierra Leone, where we collected the suspected case sample, trying to send this sample to the National Public Health Reference Laboratory Lab in Freetown, the capital city, but because of distance and other challenges, we are unable to meet the threshold. So we also have cold chain or supply chain failures in our LMICs, which Sierra Leone is not an exception to. We frequently have stock out of medicines, infection prevention and control materials, including our PPEs, vaccines, and we also, and this will lead to a distrust in our health services by the communities. We also have a community distrust as an LMIC country. You know what creates misunderstanding in the area of a health system delivery in our various LMICs is distrust, because of misinformation, disinformation, and last but not the least, the infrastructural gaps. As we speak currently, the district that I'm serving is over 166,000 populations, but with limited health facility infrastructure. We only have 50 health facility at the moment, serving this population over 160 population based on our national meter census data 2021. So our case study on Ebola epidemic in 2014-2016, as a country, we are able to record 14,124 total Ebola cases. In that, our laboratory confirmed the 3,956 deaths out of these 14,000 plus. Sadly enough, we lost about 221 healthcare workers. So, the impact of it, our routine immunization rate dropped by 30% due to this outbreak, and our health facility closed. Some were overwhelmed across the 14 districts. During Ebola regime, we are having 14 districts in Sierra Leone. Our malaria, maternal, and child health services were severely disrupted. We have intense fear from our communities that they don't want to visit our health facilities because of Ebola, thinking that anyone that is visiting the health facility will be a confirmed Ebola. So, among all these Sierra Leone learned lessons, one of the major lessons that we learned was surveillance system must be operational before outbreaks. And I can tell you for free, this one bullet point is very, very key in our LMICs. If we really want to strengthen our health system, our surveillance system must be operational before outbreaks. During outbreaks, if you're trying to strengthen your health system or your surveillance system, definitely you will miss the point. And also the community engagement is non-negotiable at all. We learned that lesson because community people were part of our intervention during the Ebola fight. Then our rapid response teams, we said, must be pre-trained and deployed faster. We also learned that our infection prevention and control training and the materials are critical workforce protection measures. We lost most of our health care or health workers because of the inadequate knowledge in the utilization of these IPC materials, in the absence or lack of these IPC materials in our country health facilities. We also learned that donor-dependent systems are always fragile. So investing in our health from our national budget is very, very good, and that has been recommended. So going forward with the COVID-19 real data from our feed in Sierra Leone, the country we are able to register 26 1,274 total cases, and laboratory confirmed 3,496, with a death case fatality rate of 7.7, with absolute figure of 125. Our healthcare workers still suffered a lot, with 1,034 healthcare workers that were infected during our pandemic in Sierra Leone. So the age category that was heavily suffered was between 25 to 44. This is quite different than other parts of the world COVID-19 data. Some parts of the world, some countries we are registering age 60 and above as the most affected age category. Some we are also recording less than that. But for Sierra Leone, the highest peak age category was 25 to 44. So the health system respond. For our DHIS2, our response was real-time tracking of all the data across the 16 districts in Sierra Leone. Our rapid response team deployed within 24 to 48 hours when we had the alert. And our community-based surveillance detected a cluster ahead of facility report, because we have our community health workers that are indigenous of each community that they are serving. So during the COVID-19, we accelerated and adopted our telemedicine. Nonetheless, our free healthcare initiative never disrupted because of COVID-19. These categories of people we are still accessing and attending to the free healthcare free. So coming to our mpox and cholera outbreak or response in Sierra Leone, Sierra Leone was able to register 5,442 confirmed mpox cases, with a case fatality of 1.1%, sum up to 60 dead. And we are able to vaccinate about 186,000 plus people vaccinated across the country. And we trace about 22,500 plus contacts in the country. So our country declared mpox outbreak in Sierra Leone on the 15th of December 2015 by our Honorable Minister of Health. So in our district, which is Falaba District, Northern Sierra Leone, we recorded cholera cases. And the peak of that outbreak in our district was in April 2024. We find out that open defecation in the communities were one of the major causes leading to that outbreak in our district. Lack of treated pipe pump water in our communities is also another one. high malnutrition rate, worsening the child outcomes of this condition. But nonetheless, our community-based surveillance detected this case 48 hours ahead of our health facility report. Then we instituted the distribution of oral rehydration shots in various health facilities in that part of the district. And we continue with our chlorination of all water source in that community. So in our building block, looking at the governance system, Sierra Leone governance structure, especially in the areas of health, the Ministry of Health is a leading organ at national level, developing, instituting our health policies. Just after Ebola, the country recommend for us to have National Public Health Agency as a landmark reform of our Ebola outbreak. So the district health management team, which is the frontline coordination across, is coordinating health and health-related activities across the 16 districts in Sierra Leone. And we have over 19 units that are attached to this district health management team. They are components of the district health management team. And in Sierra Leone, we have over 40 non-government organizations in health sector. And we also have our community health worker programs under the government oversight. The community health workers are people that are in the communities. They are trained by the district health management team, and they operate based on their policies, SOPs, and template govern them. So in the areas of health financing, as our presentation started, we have external donors. That is more than 50% of our health service delivery being supported by external donor, followed by the government, then out-of-pocket expenditure, and our free healthcare initiatives in Sierra Leone since 2010 catered for the pregnant women, lactating mothers under 5s. This has drastically increased our facility deliveries, ANC services. Then our Ebola outbreak in Sierra Leone 2016 exposed our dependency on external funding. So we have solutions for sustainable financing in which we believe other LMICs will take this for granted. One, our health tax must be on domestic revenue. For example, we will have a huge amount of tax on tobacco, alcohols, as revenue for us to have, for us to depend on our national funds. Our community-based health insurance is another area where LMICs, not only in Africa, but other LMICs around the globe, should also focus. And also our Abuja Declaration, we are in 15% of the national GDP should focus or should be allocated to health. And also have a public-private partnership for service delivery. As I said, in Sierra Leone, we have less than 400 doctors serving for approximately 8 million people. Based on the WHO recommendations, have 3 times more health workers needed for us to meet our sustainable development goals by 2030. 60% plus of this health worker based in Freetown, and Freetown is our capital city. And that is the reason why we talked about rural-urban health workers disparity. Even though we about 221 health workers during Ebola, we need more to strengthen our health system in the country and other LMICs. So our workforce strengthening method, we have the field epidemiology training. This unit is responsible for building the local capacity of the country health workforce. So our rapid response team training for surge capacity during outbreaks. And some amount of our health tax has been shifted to the community health workers and other middle level of our health providers. AFENET mentorships for early career professionals, it's in progress. As currently, we have adverts for advanced field epidemiology, and that training will be conducted in Sierra Leone. So our government is trying so hard that medical graduates will increase or has been increased by 10 times by the end of 2026. So we have also increased our skill birth attendance from 60% to 85% coverage in country. We have a memorandum of understanding Sierra Leone and Rwanda for Rwanda to train Sierra Leone personnel in the area of hospital leadership. And in the area of health information systems, our DHIS2 is being deployed across all the 16 districts in Sierra Leone. And our health information system, the government has established a health information hub with 12 dashboards in Freetown. Instead of you rely now on paper reporting, we have this dashboard that in case of any suspected case, any emerging issue in any part of the country, in any community, this dashboard can able to detect, analyze, and inform decision. So we also have our electronic integrated disease surveillance. This has increased our health facility reporting rate. Previously, we are having 3 to 7 days delays in reporting using our paper base. But now, the same day interventions or emergency happens, they will now report on the same day. So as I said, our community health workers reports is via the mobile phone. Anything happens in their community, they will now respond, they will now report to the other level through the use of mobile phone. And also, Sierra Leone is among few African nations with real-time decision grid data. If you look at our Africa countries, Sierra Leone is now one of the countries that is highly graded in terms of surveillance. So we have our innovations. As I said, the digital health and mobile reporting has increased in Sierra Leone by the use of the HIS2 real-time data, and also the Health Information Hub. That one has been established in Sierra Leone since January 2026. And also we have our WhatsApp group that report any type of disease in the country. And we're responding. We pre-trained our multidisciplinary, multi-sectorial, such as the epidemics control unit. We have our epidemiologist. We have our clinical personnel, logistics personnel, community people, agricultural personnel. They all are in this rapid responding. They are part of the rapid responding, wherein they will respond to any health and health-related emergency at that district level or community level. Nonetheless, we also have our Economic Committee of West Africa States rapid response team. Despite the country own rapid response team, we also have the regional response team, and Sierra Leone is member of that team for any cross-border surge support. Then delay within 24 to 48 hours of confirmed alert. That one has been eradicated in Sierra Leone. So any emergency will activate our RRT and deploy for action. So based on the community surveillance, we have already trained our community informant people that can respond and that can report to the health facility, various health facilities in the country. We also integrated that with our former integrated disease and response framework. So in that, we have low text with high impact, which requires only basic mobile phone. So Sierra Leone also initiated another innovations with a mobile clinic, wherein the vehicle will move from the city with medical personnel, medical equipment, and all medical interventions to a community to provide free health services to this community. It is a remote clinic health interventions, and also established a bond unit in our teaching hospital. Then where do we go after here? This question needs to be answered by each member of our LMIC country. Probably you will not answer that question here now, but put it in mind that you have big question to answer. Why? we are saying we have to increase our Abuja recommendation made by our head of state in 2001, that 15% of our national budget, our national GDP, should be allocated to health. Also, we are to increase tax on tobacco, alcohol. We are also saying to institute community-based health insurance in our LMICs. Most importantly, we need public-private partnership for us to achieve our health system in Africa and other LMICs. Remember, every dollar in health returns in huge economic benefits. In the area of digital transformation, we are saying to expand our DHIS2 to deploy AI-assisted diagnostic and to build interoperable systems in various communities in our LMICs, our health information hubs, like what we have done in Sierra Leone. These are just a pioneering step for us to strengthen our health in LMICs and other African countries. Our workforce, we are saying to scale up the field epidemiology training program, the rapid response team, the community health workers program, and to address rural-urban disparities in the area of health workforce. And also to have rural or remote motivational factors for staff that are living in the rural areas. Sierra Leone has ought to increase the health workforce by 10, probably by the end of 2026. We are also looking at our regional collaboration, that our ECOWAS rapid response team, our Africa CDC, our AFENET must deepen cross-border surveillance and joint outbreak response. As you know, no country achieves health security alone. In terms of universal health coverage, must be a cornerstone of our health service delivery in LMICs. Every person accessing quality care without financial hardship, as what Sierra Leone free healthcare initiatives prove, is a very good concept. Now, our key takeaways, which I want everyone to be member of. In the areas of the WHO 6 health building blocks, we knew all the 6 building blocks are interconnected. One missing, others will not function well. So failure in financing, that weakens our workforce, which collapses service delivery, as what we saw in our Ebola outbreak in Sierra Leone. Ebola in Sierra Leone did not just kill people, it exposed an unprepared health system that Sierra Leone was. The best epidemic response is a strong health system in peacetime and not in epidemic time. So no health intervention succeeds without community trust. From Ebola to Mpox, Sierra Leone experience taught this as a very, very cost-effective in our country. So investments always save lives. Every dollar in health system strengthening saves many more by preventing illnesses, deaths, and even cost economic disruptions. So Africa has that solutions. Africa we are living has the solutions for our health system. The DHIS2, the community-based surveillance system, the rapid response teams, interventions, the field epidemiology training programs, the health information hubs that has already been established. Africa health professionals are building a system the continent needs. Epidemic knowledge without field experience leaves critical gaps. Note that in Sierra Leone, practitioners bring unique insight from Ebola, COVID-19, Mpox, cholera, etc. Now we are recommending for our health system to be strengthening. We are saying at government and ministerial level that they are to increase domestic health budget towards the Abuja 15% target. We even need more of the GDP per country to be allocated for health system. We also recommending that to establish the fund, to establish and fund national public health agencies as one of the pillars under the Ministry of Health. Also, mandates DHIS2 and real-time reporting across all the districts or communities you are. Also to we have to invest in rural health workforce, providing their housing, relocation allowance, remote allowances, salary increment, career progressions, and all the rest. Also, we are recommending to the government and ministries of health to legislate community-based health insurance services or schemes in the various LMICs. We are also recommending to ensure free healthcare initiatives for vulnerable populations, as what Sierra Leone is doing. So for the professional and practitioner, we are recommending that we have to engage in the field epidemiology training program and to capacitate the RRT. Also to champion community trust, and also to use data for decision making, to publish and share field experience for evidence generation. We are also recommending to this professional to advocate for WASH integration into all health interventions, because there are a lot of communities in our LMICs that lack water, sanitation. also to train and mentor the next generation of public health leaders. Coming back to the regional level and global partners, we are recommending to align funding to national health strategies and not para system at all. Also to invest in our ECOWAS, RRT, Africa CDC, AFENET, cross-border mechanisms. I hope other LMICs don't have this structure, but we are recommending global partners to have similar, if not, in their various LMICs. Also to support digital health infrastructure and fund long-term workforce training over short-term project cycles. We want to recommend again to hold government accountable, especially for us that have the Abuja declarations on the 15% GDP to be allocated to the health. Also, to place Africa expertise and solutions to global governance, to global health governance. I think my presentation will stop there and have a few questions. I want to know what challenges resonate most with your health system experience as one of the questions, and also which WHO building blocks is highest priority for reform in your context. Last but not the least question for you: how can regional collaborations be strengthened for health security? Thank you, and over to you.
Thank you, Mr. Presenter.
If you guys have any question, feel free to ask or write your question in the chat box.
Hello.
Yes.
Hello, Mr. Musa. I'm Khalid Mahmood from Pakistan.
Yes.
And I'm a PhD English linguistics scholar at the University of Management and Technology, Pakistan. First of all, congratulations for a wonderful and insightful presentation. And you have covered all the health strengthening measures that has been taken in Sierra Leone over the years and for the policy guidelines. I want to ask you that Sierra Leone, there has been the deployment of the United Nations peacekeeping forces in Sierra Leone. And do you think there was any kind of contribution from the United Nations peacekeeping forces for the development of the health infrastructure in Sierra Leone?
That question is already been answered in the presentation, but I can just say a few. In the area of peacekeeping force, you know, Sierra Leone is a member of the United Nations organizations, right? So for the health system, we have WHO, which is a component of the UN organ, is an organ component of the UN system. And this WHO, some of this training that I presented, WHO is part of that training in the area of technical provision of technical expertise in Sierra Leone. During the 1991-2002 civil conflict, we had UN peacekeeping force in Sierra Leone, and they were also providing some amount of health components, especially the areas of food, like the WFP, and also children affairs, I could still recall. But at the moment, for me to say UN peacekeeping force in Sierra Leone is providing health system in Sierra Leone, I don't have idea about that one at the moment. All I know, WHO, which is a component of UN, is part of the Sierra Leone health system strengthening intervention.
Thank you. Thank you very much.
Welcome.
Hello. Yeah, thank you
Yes.
so much, Mr. Jusu. My name is Abdullahi Bobo in Regional Team for Focus 1000 in Falaba District, Sierra Leone, a public master's in public health. I want to say something about the public. I want to say something about the health system in Sierra Leone. For Sierra Leone, our healthcare system operates on out-of-pocket model. If you think about the 6 models of WHO models of building blocks, for Sierra Leone here, our health system operates on out-of-pocket model, wherein beneficiaries knife out money from their pocket to pay for healthcare services. And if you consider the health system pyramid, wherein we have the base that is very close to community, most of the beneficiaries reside within these communities that they seek healthcare services. But the pyramid of the healthcare system pyramid operates in 2 principles. One of the principles is referral, and the other principle is supportive supervision. But if you consider the 6 pillars of WHO building blocks, wherein we have the service delivery, the human resource, the health finances, the medical product, leadership and governance. But the issue here in Sierra Leone here, we have the health finances, which is a big problem. And if you consider the health system pyramid, wherein the referral protocols and also supportive supervision, these things need money, and it can only be enhanced if there is money to carry out these facilities, to carry out these activities. But for in Sierra Leone here, the challenge we have here in terms of referral, if it consider the health system pyramid, from the grassroots, which is the community, to the district hospital, from the district hospital to the regional hospital, and then to national hospital, all this involve money. Like before, there was the men's ambulance service, which was supported by NGOs, by donors, and now it is owned by the government. Several times when they make referral, the main service operators request for money from community people, just like I was saying that we operate on out of pockets. So you as a patient, when you need referral, they ask you to pay some money to purchase fare and other things. So with that, it's a big challenge for Sierra Leone here. I don't know how best that you in the Western world can really assist Sierra Leone to achieve the WHO 6 pillars, which is one of it is service delivery, human resource. Of course, if you want to embark on human resource, like what my landed brother was saying, Mr. Jusu, that across the country we only have 400 medical doctors which is very much limited for the type of illnesses that occur in the country. We need more human resource. And to gain this human resource, we need financing, which is the health financings. So how can we mitigate or to solve this problem in terms of health finances? So that's my own question. How can you help Sierra Leone to have a complete successful health financings to finance all their health activities, so that beneficiaries in the lower communities cannot pay for any services? Though we have a free health care, but it is limited to certain categories of people, and that one is not enough. The service they provide is not enough. So that's my take. Thank you. Over.
Thank you. Thank you. I hope the question is not for the presenter, right?
It's not only for the presenter, it's meant for all the participants that are online now listening to me.
Okay.
Yeah, good afternoon. Good afternoon. Yeah, my name is 𝐐𝐫𝐚𝐞𝐬𝐡-𝐁𝐈𝐈𝐇𝐑. I am a social worker, a HND holder, even though I'm not a health practitioner. But first of all, I want to thank Mr. Jusu, because of his analysis he have already made. I appreciate him a lot. Then I have learned a lot. As the two speakers have already done, this is a problem that's really affecting many areas in Sierra Leone, especially in these referral pathways. And there are certain areas where there are no ambulances even to take some of these people to bring them to the hospital. It's very difficult. But since I'm not a medical practitioner, all I want to say here, I thank you a lot, Mr. Jusu, that we are still looking ahead. What will be help the people that are responsible for most of these problems? How they can come on board to help, because medical facilities are things that everyone needs, especially Sierra Leone here. There are many areas people cannot go there, but with the help of WHO and with the help of most of you that are out of this country, especially Europe, the European world, I believe if you're able to put hands and help Sierra Leone, as Mr. Jusu have analyzed, people are really suffering here because there are no facilities that can help these people. Especially, there are many vulnerable people in Sierra Leone. But I believe with the help of UN and with the help of WHO, things will differ little by little.
Thank you. Thank you. Thank you. Any other? Any other questions, comments, contributions from the presentations? Oh,
yeah,
my brother
I have
is...
a question.
Okay,
Hello.
okay.
Firstly, thank you very much, Mr. Jusu. Your presentation was really good and very informative. Our government collects lots of money from the searchers. These searchers are mainly related from tobacco-related products, but these tobacco-related searchers, they could not properly use, especially if I mention that non-communicable disease are increasing day by day. That's very alarming. But our government, these types of money, they collect from searchers or tax who are directly involved from collected through tobacco-related products. They cannot use this use money in this the prevention or promotive activities for related to non-communicable disease. So how we use this money, or our government how use this money, especially if I mention about this, lots of the non-communicable disease, cancer, or lots of cardiovascular disease, how they use this money and how to they uh, mainly use this money in especially the promotive and preventive activities or related to which are related to non-communicable disease.
How your government will use the money? Come again with your question, because it's like, is it comment or questions? Come again once more, please. Mutasim.
Yeah.
How your government will use the money for non-communicable disease, or what?
Yeah, this question, how they use them, these types of money who are collected from our people. Now, this is a huge money, tobacco related product. Every government all over the world collects lots of money from the tobacco related products through tax or such. How they use this money?
Okay. So in the use of government money, we have what we call accountability. You have to hold your government accountable for using your money that you are generating from your government or from your country. And in the accountability section, we have what we call the Anti-Corruption Commission. This commission is already been designed and is overseeing all the implementations of government and no government, in fact, even no government fund in the country. For example, if you have your revenue from tax purely for health, then the accountability section of the utilization of that money must be very strong, because everybody wants money. In Sierra Leone, we have that section wherein the ACC, the Anti-Corruption Commission, one of their mandate is to see that all government funds are being utilized based on the design approved by the policy document. So if in your country you are having or you are generating revenue directly for non-communicable disease, the utilization of that money, you have to think and put it in mind who are responsible for overseeing this money and how to utilize it. So I think for us in Africa, Sierra Leone to be specific, probably our utilization and our approval might be quite different from your country as one of the LMICs. But in short, I think this is one of the ways for me or for us in Sierra Leone. Be accountable, be committed, and be dedicated to whatever you are doing, not only in the areas of non-communicable disease.
Thank you for your opinion. That's really informative.
Thank you.
Hi. My
Yes.
question is to the presenter. So my
Yes.
question is, which mental health activity do you think is better for refugees in developing countries like Bangladesh, as we have Rohingya refugees?
Which
mental health activity is better for refugees in developing countries like Bangladesh, as we have more than 10 million Rohingya refugees?
Okay. First, for us, you have to capacitate first your local health workers or health workforce. You know, we have gap in the area of mental health intervention, not only in Bangladesh, even in Africa, we have that. Only recently that people are now focusing in the area of mental health training and other provisions in the area of mental health. But for us in Sierra Leone, what we are doing currently, we are providing scholarship for Sierra Leone local-based indigenes to have their mental health training. We also instituted that whole component in our district health management team, in our hospital. So these personnel are currently in the district health management team. They are also in the district hospitals. So in case of any eventuality relating to mental health, these people will now come in and intervene. So I mean, one of the major areas are how you guys will strengthen mental health, especially in Bangladesh. First, you have to have mental health activity in your annual work plan as one of the initiatives. Yes. Annual work plan. In that annual work plan, you have to develop activities in the annual work plan. Whosoever is funding your annual work plan document have to be knowledgeable about the mental health intervention in the areas of personnel, in the areas of drugs, in the area of any other services that the mental health personnel is providing at the district level, at the community level, at the hospital level, as even the PHU level, the peripheral health units level. And you also motivate this personnel through the career pathway that if this staff entered as mental health officer at district level or at facility level with a very little cadre, that provides for that individual the career pathway that after this certificate, you are to go for the diploma. After diploma, the BSc in mental health, masters in mental health. So this will attract other colleagues to join the team and strengthen the human capacity. Will not stop or will not just serve as the conclusion aspect of the intervention. You also have to look at the services, how the services is being provided by the staff that you have already motivated, and now he or she is embarking on these mental health interventions at the hospital level, at the district level or community level. I think these are some of the ways Bangladesh or any part of the LMICs we look at. Thank you.
Oh, thank you.
Any more questions? Yes.
Hello,
Tabib,
sir.
Tabib. Yes, Tabib.
Hello, sir. Can I speak?
Yes, you are at liberty to speak.
Sir, I am Tanvir Alam. I am a student from Bangladesh. I am currently in my third year doing BSc in Medical Laboratory Science. I want to talk about collaboration. Like in your third question, you asked about regional collaboration.
Yes.
So I observed your whole presentation and it was good and informative. Like you have less than 400 doctors in your country, right?
Yes.
So if you increase regional collaboration, like joint training programs more and more, so I think it will help to recover that situation, like in your health section, doctors,
Yes.
medical technologists, and also there are a lot of people in your country. So to maintain these patients, you need to a lot of lab resources. So how do you manage all of this, like from laboratory and doctors, everything? Like in WHO, we saw the ratio, like for every doctor, we need at least 5 technologists, medical technologists. So there's a shortage in here. So how do you manage this?
Yes, so what Sierra Leone did in previous, we are in collaboration with the regional corporation that we are talking about here. So the country, we are inviting doctors or other health practitioners from other parts of Africa, like Nigeria, other parts of Africa. So these doctors we are coming in Sierra Leone because of the shortage of doctors that we have in Sierra Leone. So they were assisting our home-based doctor. And what currently the ministry is doing is providing more scholarship for our local colleagues, local based, for them to be for them to continue with their training in other parts of the country, like what I mentioned in the area of the MOU that's signed between Sierra Leone and Rwanda. So the country is also aware of the shortage of doctors or medical staffs in country, and the strategies for us to look at that keenly. One is to provide a scholarship, and 2 is to expound the training universities or colleges in the country. Previously, before this time, Sierra Leone was having only one university that is responsible for the training of health professionals. But as I speak currently, we have more than 4 universities that is training health staff in the country. So probably within 5 to 10 years time, Sierra Leone will no longer talk about shortage of doctors or shortage of health providers in country.
Yeah, I saw that you are doing great in medical graduate, like medical graduate increased 10 times than before. So
yes,
it's everything. But I think the main problem is, there are so many problems, but I think the main problem is funding, right?
Yes, you knew very well. Is that?
Yeah. So thank you very much for presenting this amazing presentation. And is there any way to connect with you, like your email or something?
Yes. My email is on the slides, but I can still send it now.
I cannot see anywhere.
Okay. No, I'm not sending it now in the chat box.
Yeah, it would be great.
Yes.
So are you in Ministry of Health of Sierra Leone, right?
Yeah, Ministry of Health in Sierra Leone.
That's amazing.
Yes, I shared my email address in the chat box.
Thank you so much.
Most welcome, sir. Any more question, comments, or area need for improvement?
Hello.
Yes.
Yeah, my name is Redwan. I am from Bangladesh.
Okay.
I saw the slides, and these are based on mainly World Health Organization's health system building blocks. But I see that there is no way to integrate all system blocks under one umbrella. I think who should take the responsibility of establishing these building blocks?
Okay.
If I want to share the country's current scenario, my country's current scenario, that is About 70% of healthcare costs are borne by the households. So large amount of money are going away from people's pocket or households' money. So in such a condition, we all know that there are around 16% households facing going into poverty due to mitigating these health costs. And the consequence is going beyond our control. So how can we establish these building blocks more efficiently and in a systematic way that we can solve these out-of-pocket expenditures and also covering or pooling the healthcare resources?
Thank you very much for that question. I think the WHO building block is the central point is human approach, is human centered. To which, without the indication of a human center in this presentation, take it for granted that you will never accomplish this approach in the system block without the intervention of a human. So accomplishing it needs a lot of initiative as well. It is just a matter of not we as an individual, we need government backing. If you look at the funding source, as what you are saying directly, in your country, 70 or 75% of the fund is directly coming from out of pocket. Also in Israel, also in another part of the world, was the LMICs. So, savage in that condition, we need government response, proactive government response, because there are a lot of loopholes so that needs to be addressed before talking about reducing out-of-pocket expenditure on health. Like what we are doing in Sierra Leone, as you heard from my colleagues, the same Sierra Leone, the free healthcare is just providing for few categories of people, probably 5 categories of people in the country. And that's also not sufficient based on the demand. So what we need now, currently, we need the intervention of universal health coverage. We need to strengthen that one, wherein health services will be accessible, will be affordable for everyone, and equitable for everyone, irrespective of your region, your district you are coming from, your political parties, and you name it. But we need to strengthen our universal health coverage in various LMICs. So the out-of-pocket utilization on health we reduced. So I don't think, or I don't know much about your country, whether the universal health coverage is operating in your country. And even for us in Sierra Leone, we have launched that one, but as what we are seeing, the funding is very, very minimal. So for us to achieve that, we need robust initiative for Sierra Leone to achieve. So I think your answer to your question is to strengthen universal health coverage. Thank you.
Thank you. Thank you so much.
Thank you so much. We reached the end of today's session. Thank you, Mr. Musa, for such an insightful and engaging session on strengthening health system in Africa and low and middle class countries. And thank you to all our participants for your active participation today. On behalf of BIIHR, we truly appreciate your patience and look forward to welcoming you to our upcoming session. Have a wonderful evening, everyone. Thank you.
Thank you.
Hello.
Hello.
Yeah, thank you, Mr. Jusu. I think I will make use of this extra time you are offering us.
Okay.
So my concern is the intermediate goal for the WHO 6 pillars, which is access to health, coverage, and qualities. So for instance, in Sierra Leone here, the government contribution to health system is just 3%. 97% is done by WHO, UNICEF, and other donors. So I want to know, what are the plans set by government to combat the 97% in case UNICEF and WHO could not provide those support? How can government strategize to fulfill the 97% in the absence of donors supporting? Since we all know, we are in Sierra Leone, we know that government only contribute 3% to the health system.
Yes.
So what
So
are the
that's
plans? So what are the
yes.
plans made by government to cover up in case donors could not fund the 97%?
Yes, so that question. The answer is in the presentation, that we are to hold our government accountable for the 2001 Abuja Declaration for the 15% our GDP allocation to health. So that is one aspect, and that is very, very much strong. If we have the 15%, what they signed in Abuja during the 2021 meeting that they had, summit or whatsoever, if we have that up, they already approve it, but it is not, it's far, far, far below the actual what we are receiving in the health. So if we have, if we really hold our government accountable for that, they see reasons why they should allocate 15% of the GDP to health. And I think that will be one of the major areas where we'll be supporting or being providing for ourselves, instead of we rely on the donor funding. Then another area also is our taxes. There is need for us to really strengthen our taxes on tobacco, alcohol, and all the other goods that are not human friendly. So if we increase that taxes relating to health, we can also look at it in positive form. So these are some of the areas for me I will recommend, and everything is in the recommendation that I will presented. Thank you.
Thank you, Mr. Jusu.
Yes.
Thank you, everyone, for your active participation. Today's session ends here. Thank you. You can leave now.
Okay.